Hello, Mumbai.
चलते
This is C3.
Hi, hi, Harish here.
Do you copy,
Yeah,
Mumbai?
regular. Yeah, I can hear you. Arey,
We're
run
going to
through
go to
there.
our we're going to go to our live case.
Yeah,
Sir, look the camera. Look the camera, sir.
yeah.
Hi.
Hi.
Good morning, Florida. Good morning.
afternoon.
Good afternoon. Calling from talking from Mumbai. Here, Dr. Harish Mehta and myself, Dr. Reddy, and my cath lab team, brother Praveen and sister in charge, and cath technician Nirmal and
पढ़ लो.
uh,
कौन सा
Jose.
Run through है ना? अरे पढ़ लो जल्दी. You talk now.
Where is the slides? This is one of the headquarters hospital of the Western Railway, which takes care of nearly 1,50,000 employees, and the dependence comes to almost 500,000 employees. This has got a cath facilities with rotablator and integrated IVAS and all other IABP plus with ECMO facilities and all. This is one of the main center in Western Railway who does regular interventions.
So we'll show the case.
On the case, I am going to present today's case. Where is the
Can you
slide?
hear us?
Hello, can you hear us?
Yes, you're coming through loud and clear. Yes, we
Yeah.
can hear you fine.
Yeah.
Yeah, I am going to present the case. Where is the slide?
Slide. Please.
The
First
case,
slide.
he is an 64-year-old gentleman. He had a typical exertional angina, and his stress test was strongly positive and at a moderate workload. His 2D echo shows a concentric LVH with a normal LV systolic function, and his routine ECG was normal. He is a known case of coronary artery disease, undergone a PTCA to RCA with a drug eluting done in the year 2010. And now this time angio was done, and it just shows that there is a patent stent in the right coronary artery, and the POVA which was done to the ramus intermediate, that is also was patent. Now in this present symptoms is mainly related to the a new development of lesion in the LAD.
Can we show you? Can you see the angiogram? Can we show them the angiogram?
Go ahead, sir. Go ahead.
Yeah. The angiogram shows, this is an angiogram which baseline angiogram shows there is an proximal LAD lesion which is almost 90%, and it is LAD is highly calcified. The calcification is seen from the proximal to the up to the mid segment, and there is an involvement of the diagonal branch which is also highly calcified, and it's very angulated. And the plan was to, initially we thought we'll put the wire to the LAD on the diagonal, but we had a LED wire was easily was put with a regular or run through NS wire, but we tried to put the wire into the diagonal, but because of angulation and calcium we could not able to achieve in spite of using the micro catheter and the balloon support. And then we decided to directly take the balloon and dilate the pre-lesion. We tried to use an OCT catheter, but that also could not pass across the lesion because of tight lesion, and has to be required a pre-dilatation with an 2.5 mm balloon. Multiple dilatations was done. Then now at present this is the status of this artery.
So finally, we had a tortuous diagonal, as you see, a calcified LAD diagonal bifurcation. We finally got a pilot 150 across, but if you see the distal doesn't seem to be in the true lumen, and there was no way I could cross anything else. So we decided to pull the wire out and rotate the LAD artery, because the OCT catheter also couldn't go through despite the pre-dilatation. So we'll show you the rotational atherectomy we have done to the LAD. Next. That's a 1.5 burr. So now I'm going to put an OCT catheter through the LAD lesion, and let's see how it looks now. In the meantime, do you have any questions? Or what do you think is a plan we should do? Can you hear you?
Since the lesion was very tight, were you able to wire with the rota wire?
No, I
no.
wired it with a regular run through
run-through
NS
NS.
wire. And since I couldn't pass the OCT or anything else, so I thought let me just exchange it with a micro catheter. So micro catheter went easily. Now you see the rota, this is still struggling to go in. Can you see that? The OCT still struggles to go in.
Yes, we can see that.
Yeah, and despite this is despite a 1.5 rotational atherectomy. So now what do you think? Should we put a stiffer wire through a microcatheter and then try the OCT,
Or stent it.
or stent it and then do the
Then-
OCT?
Try that, or maybe small balloon inflation.
Okay, after the rota we can do that. Yeah,
I would
we'll do that.
probably pre-dilate and OCT,
Yeah.
size the vessel and then stent.
Okay, let me try the pre-dilatation.
With
So
a
we'll take a
2.5 balloon, 2.5 balloon or 3 we can take directly.
2.5
think-
NC, 12.
The vessel looks 3 highly calcified vessel. I think 2.75 or 3 are adequate pre-dilatation. Then try again OCT catheter.
Can you give us the balloon, please? 2.5, 12.
2.5, 12. 2.5,
So any other suggestions for the diagonal, because it's highly tortuous?
2.75 will take.
Would you, yes, I was going to say, would you try to wire the diag now before you pre-dilate?
Yes,
Okay,
yes.
we tried that for 10-15 minutes. It took us a long time to get a simple wire down. We finally got a pilot 150 down, and that was with extreme difficulty. But do you want me to try before, or you want me to pre-dilate before? Because looking at the last shot, if you can show the last frozen image, what do you think is the chance of succession in this diagonal crossing soon?
Dilate this.
Could you see
At a
the?
good angle and diseased osteum.
Yes.
Disease and calcified highly.
So suggestion of wires.
I try with Fielder XT first.
Okay, we tried that too. We can try that again.
Chalo.
But I was just wondering, in the interest of time, probably let me pre-dilate a bit. Maybe that will help us more later. Is that okay?
Yes, that sounds reasonable.
Sure. So that's a 2.515 NC balloon. I think the other problem is the angle with the calcium that's preventing the OCT catheter to go in. Go higher. Go higher.
20.
Correct.
Approximately.
Yeah. And that's the
What
proximal is a
pressure
very
are you
tight
going
lesion.
up to currently?
We are
20.
we went up to 20 atmospheres. Hello. Can you hear me? We lost
Hello?
the audio.
Hello?
We lost the audio. 20, 22. 22. Can you hear us? Go 22. Can you hear us now?
Yes, we can hear you.
We went to 22 atmospheres,
Hello?
and there's still some waste in the proximal LED. Can you see that?
Yeah,
So probably we should try a scoring balloon or a cutting
yes,
balloon.
we're able to hear you. Can you?
Yes, we see a clear waste in the proximal
Yes.
LED. So
And that's at
some
22
further
atmospheres.
optimization needs to be done
24.
there.
Yeah. So maybe a scoring balloon or a cutting balloon.
मेरे नहीं यार
So we have an angiosculpt and a flextome. Yeah. No, 6 or 8.
Could try flextome, maybe
Yeah.
harder to cross that lesion.
Yeah, we'll try the flextome, but the lesion looks better, so I think now it will cross. Now you see the diagonal. Flextome.
Yes, we see it very tortuous, angulated, calcified, disease.
I was just wondering that if I don't cross that in another few minutes, then we should probably leave it. It may remain like this. Because to rotate that artery also is going to be a challenge with that bend and all that. You agree?
Agree. Would you try an angled microcatheter to
Yeah.
give you a little more direction?
Sure, we can try that.
We can.
Or we can
What is this?
probably try a crusade
Size 2.5.
with 2 holes.
2. No, this is a cutting balloon. 2.56. Now
We've
we
taken a 2.56 flextome now.
I guess the first thing is to dilate the proximal.
Yes. So we have taken a 2.5 flextome, hoping that it will cross. It does cross. Okay, sure. Yeah, so it does cross the lesion.
okay,
Yeah.
we can dilate here. We'll go
So
here.
you can go up slowly.
2, 2, 4, 6.
I can't see anything. Okay, can you go up again? So in the meantime, if any questions, any suggestions? 6.
6, 8.
You always use rotablator or you use
8,
CSI orbital atherectomy?
No,
as
we
well?
started with the rotablator.
10. 10.
I think how much
Do
percentage
you have a preference of one over the other?
No, because I don't think this lesion would go with a direct cutting balloon at all, right?
Yes, I think I was asking orbital atherectomy versus rotational atherectomy.
We don't have an orbital atherectomy, unfortunately, in our country, so we have no
What is the
experience with
maximum
that.
pressure?
So you could help. You could tell us more about that.
Down?
10,
10.
I'm going to 12 atmosphere because it's an undersized balloon, so we can go slightly higher pressure.
12. 12. 12.
Okay, now.
We gone up to 12 with the cutting
I
balloon.
think it's more of an operator preference. Both devices work.
Orbital atherectomy in the United States is much more expensive than rotational,
Okay,
but the ease of use is very nice with their way they have the setup.
okay. Yeah, I think so. I've heard about it. I'm sure once we have it here, we would like to experience it.
My good analogy is it's like comparing old BlackBerry versus a 8th generation iPhone.
Okay, it works as well.
Both can make a call.
Yeah, sure.
Yes. Oh, city?
No, I think the big advantage is that it's a single crown. You don't have to change the burst size, and it can go through a 6-trench guide.
You see that it still doesn't look very well expanded. Let's hope we can get an OCT down there.
Agree.
So would you take a higher size cutting balloon? Or maybe a 3O?
If OCD does not go, then yes.
Okay.
Can you remind the audience how old this patient is?
This is 64-year-old.
64.
And it's very common to see calcium from 40 onwards in our country. OCT is still struggling to go down. Yeah, it doesn't go down easily.
That catheter is getting so.
Why is it? Should we'll try a buddy wire?
Would you upsize your rotablator burst size?
We went up to 1.5.
1.5 bar. We'll feed it with a 3 mm balloon.
Or should we do a 3 mm
balloon,
flextome first?
I always have concern
Sorry?
with using rotational atherectomy after you use a high pressure balloon. Seems
Yeah.
like it could lead to dissection.
Yeah, I think so. He already has some dissection below
Section.
the diagonals.
So we'll go with 3
So it's not the best thing to do unless you have to do. And I feel it is the calcium spur and the wire bias that is preventing the OCT catheter to go there. So maybe just changing the wire would help, or buddy wire next to it.
Give the one more wide.
Run through.
Run through then.
What is your suggestion? Or should we do a flextome trio over
So
there?
this is Keith.
Yes, I can hear you, Dr. Callan.
Run through door late.
So this is Keith Allen. I'm the token surgeon on this panel, and
Sure.
I'm looking at the angiogram, and I'm going to be contrarian and say you've got a nasty diagonal proximal that's a juicy target distal. Your LAD distally is a good-looking target, and your OM's got a tight lesion in it over there too that I can see. So do you have your surgeon on speed dial?
Yeah, he was with us. So, I mean, I agree with you. This could have
You got
qualified.
great surgeons in Mumbai, I know.
Yes, we do. Actually, we did think of surgery in him also. So, to be honest, we wanted to showcase this case. So, that would be the reason that we are doing this actually. So, if you personally ask me that if this lesion deserves a CABG, yes, it deserves a CABG.
Agree, very tough case, but you're making progress.
Let's hope we can do enough for you to see before you leave us. Can you come to caudal, please? Yeah, okay. ठीक है. Go back to cranial, please. Can we have the OCT again?
OCT was the body wire?
Yeah.
Body wire or previous wire?
Yeah.
Body
So
wire?
we're trying the OCT again.
For the body wire?
Otherwise, if it doesn't work, then we'll probably take a 3O flextome. What's the opinion of the panel there? Dr. Allen? I think Dr. Yadav is also there.
So I guess it's
Yes,
so when I run into this situation when I'm doing peripheral vascular work, but as a cardiologist, when do you say enough is enough? Because what you don't want to do is jeopardize that distal
agree.
LID, which
Of course.
I maybe have already some concerns about.
Sure. So if we don't, if we
I think
can't
we are at
manage this,
point that it's probably better to proceed at this time.
1000 apparent.
sorry, I can't hear
I
you.
mean, proceed with
Yeah.
PCI. And
Yeah, of
keep
course.
doing what you're doing.
We always have the option of sending him for bypass, sure.
Yes, let's see how this flextome goes.
Right now we're trying the OCT on the body wire. If it doesn't do, then we will do the flextome. I think we need another catheter. The catheter is gone, I feel.
One more catheter.
I feel the
was-
catheter is gone. Because how it should go? I mean, why should the OCT catheter not go? Come on, it has to go. Yeah. Okay, I'm going to take a flextome because I can't get the OCT through.
One more was the catheter.
Sure, flextome scoring.
Yeah.
Upsize the flextome.
Can you give the flextome? 3O?
3.
Yeah.
Have you thought about
Yeah.
delaying the OCT until after stent implantation?
Yeah, that's the. I think now I'm going to do just that. Probably open the vessel, stent it, and then do an OCT how it looks. Because I'm not going to try any more OCT after the flextome. But with the OCT not tracking, I think the stent tracking may be all difficult too. So we might need a guideliner or something.
We'll be taking out one wire.
Do you all take a wire out when you're doing a
What is your
flextome?
preferred approach to bifurcation?
Generally, depends if it is not a large diagonal, not a very osteal disease, then obviously provisional is the best approach. Otherwise, would be a DK crush versus mini crush. Do you remove the wire when you do the flextome, or you all keep it there?
There are 2 wires now.
I
One
would move
wa-
it back. I would worry about wire fracture.
Okay, okay. Yeah.
Can we just see where we are?
Yeah, we'll go here.
Slightly back, yeah.
We'll go here.
Yeah. So we have a 3 of flextome 6 at that position now.
I think that's somewhat a good sign that a 3-0 flextome went, at least your stent will go. Question remains whether it will expand or not.
Yeah, that's most important, right? Because we don't want to give them a suboptimal
Yes.
result in the ostial LAD.
Yeah. We are at 10 pressure.
Absolutely agree.
Can you show me?
Yeah.
So it's there, it's still, the lesion is still there, so we have not really
Going
scored
again.
it out.
Going again. Going again.
Yeah.
8, 10.
That's enough. So you see the waist is
So
still
yeah.
there at 12 atmospheres.
Have you seen any focal dissection?
I'll just show you a shot. Go down. Inject. Yeah, there's some
No, no,
dissection there,
dissection.
very little.
Go again. Go again.
So
Go again.
what do you think at this stage? The still it's there, the lesion is not fully
No,
expanded.
not as. Yeah.
Would you stent? Would you not stent? Because I can't get the OCD down to really see now.
Yes.
If your flextome's not expanding at that high pressure, I doubt your stent will expand.
that's true.
You'll have a
Yes.
big waist.
That's true.
Yes.
And that's not worth leaving it at that point.
What do you think of stenting the distal or the mid LAD so
And
that
then-
that part is safe,
and then we think of that.
reconsider
Yeah.
For sending him for
rotoblader?
bypass.
I know this is not ideal, but you
we
may
did
have
have-
to rotoblade this proximal. for the
Probably we'll
bigger
have to
burn.
go with the bigger 1.75 or something.
Yeah.
Okay, so let's do that. Let's
Right,
probably
but before
stent
we
the.
go that, maybe think about stenting the mid,
Yeah,
Yeah.
just so that the mid vessel is stable.
sure. I get your point. So I think we'll stent that.
And then if you may want to replay the angio and see is there a landing spot so that we don't cover the diag, just so that it
We'll have to cover the
Doesn't
diag.
close.
So we'll take you a shot again. We'll show you a shot.
No, last shoot.
Let's take a last shot. Show them the last shot.
No, no, it won't be.
Before the flextome. Before the flextome.
How high pressure did you take the cutting balloon?
We took
we
a
went-
30 to 12 atmospheres.
Yeah.
Would you want to go higher than that? Because it's a very big balloon for that vessel. Would you take a 2.5 to say 16
you're right,
atmospheres
you may have to cover it.
at a higher pressure?
I would consider taking a 3.0 non-compliant in the proximal vessel and taking that up high pressure if
Okay,
your
we can
intent
give
is
that a
to
shot.
keep,
Okay,
Yeah.
we can do
we
that.
can try.
moving forward with the
3
PCI.
So we
non-compliant
get
balloon.
309. We can try that.
Throw 9 non-compliant balloon.
Actually, when I saw this angio, I didn't think it was going to be as
But it is,
calcified as it
yes.
appears to be, but it is really very, very calcified. So, any suggestions in the meantime? Is Dr. Dave there also?
No, he's not on the panel right now.
Okay.
What is the length? This is 9, no? Yeah,
So
now.
I'm just taking a 309
the
NC Sprinter
NC
there.
Sprinter.
What is your choice of anticoagulation for this case?
We've used heparin. Do you all use regularly buvaluridine or what? Sure.
Sure.
Most of the cases at our center are using heparin in the setting of this type of PCI, but Angiomax is used selectively because of
16,
cost.
18.
20. So we are
20.
24 atmospheres with a 3.0. It's still not giving up.
Not.
You see that?
Right, still not.
Yeah.
Down.
22, 24.
I think that idea of preserving the distal vessel and then probably think what to do with this later at probably 1.75 rota.
I was in your situation, I think that would be my choice to stent
think
the
so, yeah.
mid-segment, stabilize that,
Yeah.
and then you will think of rotoblading the proximal.
Yes, I think so. Okay. So let's select the stent size, 2.75 down. If this inflated balloon doesn't go down, I doubt very much that the stent will go down.
What is the stent will take?
See, this balloon doesn't go down beyond this point. So I doubt very much that it will
Can
go
you
down.
delete this again down? Can you delete in the same balloon?
Go in the. You agree?
Any thoughts about reconsidering surgery as an option?
Yes, absolutely. That
Abso-
thought is
yeah,
on
that is
all
always
the
there.
time. I think if I'm not be able to stent that low part, I'm definitely going to send him for surgery. Because the proximal lesion just doesn't seem to
Yeah.
give way.
What wire is this?
Why
This
is
is run
still
through
there?
NS. I might put a grand slam by the side and see how it goes.
Yes, that's what I was asking. That maybe a
Little stiffer wire.
given the
Yes.
support.
Yeah.
Can you give me grand slam, please?
This, no, not this.
Grand slam.
See the fluoro? Which wire has come out? Fluoro? Grand slam wire there, no?
So in case we leave you sooner, then we will keep you informed what happened about the case.
You have about 5.5 minutes.
Okay.
Keep working.
Sure.
This is a very
Yeah.
challenging case.
अपने पास 10 मिनट है सर.
Okay, sir. Okay. And grand slam, please. Do we have 1.75 bar?
1.75 bar, no.
How often do you all use 1.75 bar in your cases?
It depends on the vessel target. For something like a proximal LED, it'd be very reasonable, and it will still fit through your guide. So that's not a bad choice.
.75 bar may be too big for this artery.
That's why I do orbital atherectomy. Don't have to think about burr sizes
Right,
and
right.
guide
Yeah,
sizes.
yeah,
agree.
yeah.
I wish we had that.
Yeah.
Are you caudal?
Array caudal.
Okay.
Come to cranial.
Cranial?
Cranial.
Okay. So we have the grand slam down there. I generally like to
Which balloon you want?
take it on the previous vessel
This wire.
because one is sometimes your subintimal and second is
Which balloon you
the
want?
grand, the same three. And
Three.
second is sometimes the stiffer wire doesn't take the stent or balloon very easily.
Now again we have taken 3 NC balloon 3 9. Oh, the regular.
Grand slam कौन सा है? No. We generally prepare the balloon in the guide that helps us to profile the balloon better. See that despite having a support of this grand slam, the expanded balloon doesn't cross. So that tells me that the stent won't cross that easily.
True.
Yeah, it's
Yes,
crossed. Okay,
yes,
that's good.
it is cross.
Sure.
Yeah, we'll go
You
here.
can do it a little bit here. Yeah, just with the lower pressure because it's a 3/0. This may partly work as a cutting
12.
there.
12.
Since you have 2 wires,
12.
down. I think the problem is probably has a long circumferential calcium everywhere.
Right, it's a tram track calcium.
Yeah.
Very heavily.
And it's all the
calcified
way.
vessel
It's
and
all the
long
way.
segment, not
Yeah.
just a focal
Yeah,
point.
it's all the way. I agree.
Approximately. We'll try approximately.
Let's do it here at this point. Yeah.
14.
Down.
Approximately. Good.
Wire mix mat karo. Where's the other wire? Won't mix the wires. So we'll do it later. Okay, go up here again.
Check
Yeah,
approximately.
we are good. First, let's do this and then we go proximal.
Yeah. 14.
Down.
Approximately.
Yeah, same.
Oh, here?
place, Yeah.
Sixteen.
20.
20.
Yeah, just doesn't give way.
Still there is a lot of waste. 20.
Okay. Now. Yeah, so I think we'll start strengthening the distal and then take it from there.
I think one of the things you have to consider is if you stent the distal, then what are you going to do with the proximal in case you're, like, what's your plan? Are you going to
No, I
rotablate
think
it further
I think so. I would like to rotablate
or
it further.
leave it
yeah.
alone? Because if,
Leaving it alone wouldn't be a good idea.
It's all
Can you hear me?
agree.
Yeah.
Like
Yeah,
if,
leaving it alone
you're
would-
thinking of
Stent.
surgery, then
Stent.
Probably
why
send
send
it
the
right
mid
up.
segment?
Stent.
And send him right
Stent.
away. Yeah, I got it.
What stent will take? 3?
So let's take a shot first.
Yeah.
We have a dissection,
Dissection.
distal
yeah.
also.
Mid to proximal dissection is there.
Yeah, do you see that?
Yes, we see that, and you may need a long stent.
Yeah. Probably we'll take 3 size,
No,
3
2.75.
2.75 or 3.
Short one first and then take another one above that. The long stent wouldn't go.
Right, long may not go, long 30 may not go.
Yeah.
So
Probably take an
We'll take
18
a-
and take another 18 after that.
18. 2.75 18.
yeah.
Yeah?
I think it 3 also.
You can have an 18?
We agree. We thought 2 medium length stents would be better than 1 long
Yes,
one because
yes.
of the difficulty getting distal.
Yeah, 2. Which wire?
And I heard someone speaking of propofol on the sheet.
This.
Dr. Reddy,
Yeah.
Dr. Mehta, we have about 50 seconds left
Sure.
for the transmission. But thank you for sharing this very challenging case. We understand. I mean, this is real life scenario. What do you do?
Yeah. Thank you for
Thank you,
letting
thank
us
you.
be a part
No.
of this good meeting, and we appreciate your patience. And let's hope we succeed, and we'll keep you all posted what happened about this.
Great, thank you.
Thank you.